Oh, okay. But Zoom nankasa wo very good feature be like you can easily do it without going anywhere. Oh, okay. But Zoom nankasa wo very good feature be like so let me share the YouTube link with the others. And I'm the actual CEO, no. Yeah, I think it's also live there. Um, I'm pretty much good to go. Please, those on Zoom, Simon, Perry, and the others, can you guys hear me? Just let me know if you can hear me.
Yeah, we can hear you.
Oh, thank you so much.
Yeah.
Oh, yeah, what you mean, Ka?
Yes, sir. Please, I can hear from you. Harry.
Hey, okay, yeah. I was talking to somebody on the other side. Let me go and see what has happened to you. In Shira Bruno, me pachote minka. Coco, do you hear me? Like, can you hear me? Oh, great, 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 great. I think we are quite good to go. Technology. Wow. Hmm, you get there. So thank you, Coco. Thank you, Shira Bruno. These are people joining us from TikTok. Guys, it's time. Can you kindly post on the pages that we are about starting so that we rock and roll? $25 is quite low. Please call them. At least we should be getting 50 participants, at least. Tell them that we've started. Somebody should volunteer. I mean, send it to the main page. We can kickstart so that we can all be on the same page. Thank you. Those sharing, I appreciate you. I think we're still not even 30. By it's time though. I'm going to give a grace period of just 2 minutes. It's 11:31 here in the US, EST time. And in the next 2 minutes, that's probably 11:33, I should be so I think we have about 5 participants or so. Coco, thank you. Thank you for liking. Coco is really Coco is doing something who's this? Can you please increase the volume? All right, I can. For the others, just so I don't shout too much. Somebody is requesting I increase the volume. How do you hear me at your side? Those here on Zoom. Am I too low?
No, it's okay.
No, please. It's okay.
I think it's fine.
It's fine. Okay.
Um,
Then please, Sister B, can you kindly check? Oh, yeah. Priscilla said the volume is low. Abigail said the volume is low, but most people are saying it's okay. Those who are saying it's low, there is a feature of Zoom. Zoom normally prioritizes other applications over its sound effects. So if you were on a call or you had other applications opened, if you're using a mobile phone, it would be nice at this time to close those applications off, or make it better, just log off and then come in again and see the difference. Sometimes it works out. And so Priscilla and Abigail, if any of you could give me a feedback if it works this time around, I would be grateful. I see Prof say so. Hey, senior, in Bruno, Akonobia, and Coco, na me other line on TikTok. Thank you so much, guys. I really appreciate you. So Abigail or Presla, if any of you is okay now, then I think we could go. But don't, if it's not okay, don't pretend it is. There's something we can do to help you. It's better we all get it all. Why? I say the technology. Technology will be able to know streaming on different places at the same time. I didn't have to use much applications. It's just one laptop, and it was just enough. One laptop was just enough to do all this. Didn't even bother getting any applications elsewhere. We are 42. I think it's quite okay for us to start. And so I'm going to give this whatever. Is it a disclaimer or what? Okay, guys. Good morning, good afternoon, good evening. I greet you wherever you are. You are welcome to NCLEX review. And today we are going to look at psychiatry. Before I start, just want you guys to know that this session will be recorded. But unfortunately, it will not be given to you. The host is going to keep it for his own purpose, for evaluation's sake, maybe improve how he delivers some of these things and all that. If you are not okay with you being recorded, which in case sometimes you may mistakenly put your video on, or sometimes unmute yourself unwillingly, it will all be picked up, including certain actions you didn't intend. I'm giving you this opportunity to leave us alone at this particular point in time, so that we will not we stand blemish of any other issues before I hit the record button. So if you're not comfortable being recorded, then this will be a very good time to leave us alone. Okay. So I'm starting the recording. Okay. Good morning, good afternoon, good evening once again. My name is Samuel Asamoah Boateng. I am a nurse in the US. I work as a nurse manager in a cardiovascular bariatric surgery, medical, surgical, and renal transplant unit. I also do help students with NCLEX as part of my leisure time activities, not a part-time business. Yeah, I was a nurse in Ghana. I went through almost all stages of nursing that you could think of in Ghana. I was a diploma nurse. I had bachelor's in nursing. I did my master's. I also have a master's in healthcare management, and I specialize in palliative care with the Ghana College of Nurses and Midwife. In the US, I'm currently doing my nurse practitioner program. I'm also in my final year of a PhD program, which is also in palliative care. I've done lots of publication in palliative care, and my research area mostly is just improving quality of life, especially in low resource areas like low middle income countries like Africa and Ghana, my good country, Ghana. Yeah, that's what my research interests have always been. Today we are looking at psychiatry, and it will be more of me talking. Okay, you see, psychiatry is focusing on patients with mental illness, or in certain instances, some sort of mental distresses. If I give you a chance to mention, since most of you are nurses, I'm pretty sure you're going to mention a lot: depression, anxiety, schizophrenia, a lot of these conditions. But I mean, we also want to understand the experiences these individuals and go through, and then how best we could help them in as much as we prepare for a board exams. Okay. Now, this particular idea I took from one of the popular reviewers of NCLEX called McClimack, and I'm readily acknowledging him as one of the great motivators in some of these things that we do. He said that when you get any questions regarding a psychiatric condition or patient, you need to ascertain whether the patient is psychotic or non-psychotic. So is the patient psychotic or non-psychotic? How do we determine that? He's saying that if the patient is non-psychotic, then the patient has a grip on reality. In other words, he understands what is going on within his environment. So for these kind of people, therapeutic communication is very important. That is what you're going to do. So a person comes to you in the clinic and he says, Charlie, things are not well. Oh, to be honest with you, things are not well. Like, I'm not able to eat well. I can't even sleep. I feel worried, that kind of stuff. So it's like the patient is able to tell you what is wrong with him or her. The patient understand what is actually happening, right? So they are telling us to use therapeutic communication. What would that be? So therapeutic communication is something that is going to support this individual emotionally, psychologically, sometimes physically, and even all aspects of life in a very good holistic perspective. So the aim of this therapeutic communication most of the time is to, one, build trust, promote insight and expression, support problem solving, and empower the patient to make decisions. You're not going to make decisions for the patient, but since the patient has entrusted you and brought his or her problems to you, you are at this moment going to assist the patient to make such decisions, right? So there are some key principles in your communication. You're not going to necessarily use the phrase, I'm going to be in your shoes. No, his leg size is quite different from your leg size. So don't be sympathetic. You're going to be empathetic. Whereas, like, it must be very difficult for you. Don't say, I know exactly how you feel. The patient comes to you and say, Charlie, these days I'm so stressed. I say, Jimmy, stress, you are talking about stress. Me, I have been managing stresses. I'm even a branch manager at Quadasu Estate. You yesterday you come into this game, you started complaining. You don't know where life is going there. No, not that kind of answers. They want you to say, this must be very uncomfortable for you. This sounds like a huge challenge. Oh, wow. This might be a hurdle. Oh, what a scene in your life that you are, right? These are quite acknowledging what the patient is going through. So you say, can you tell me more about that? You use open-ended, not things that will just cut it off. How are you? Then obviously the answer will be like, I'm fine. But if you put it like, how have things been these days? I mean, it's quite a little bit open as compared to the how are you that would need a strong answer that ends the whole conversation. Sometimes you need to reflect. The patient gives what I call a punchline. The patient says something of that nature, and you don't let it slide. You don't let it slide. You say, hold on, did you say you want to give it up? What do you mean when you say you are giving up? Right? At times too, you do what we call empathic presence. You remain silent, allow the patient to go through. You ask the question, the patient is quiet and it's like that. Then you ask, Mr. Sami, are you okay? Yeah, I'm okay. Then you shut up. You allow the patient to think it through. That silence is okay. Clarify what the patient means. Okay, you restate it. Sometimes you focus on an area. You were driving the patient to a particular plan with you. You guys were talking about his illness. All of a sudden, the conversation has shifted to his cocoa farm. So it's a skill in you bringing the focus back to what we are trying to solve, right? The patient is having troubles, and probably as a matter of that, it's making the patient have flight of ideas or shifting the goalpost each time you guys are having anything. Then sometimes you summarize, and this is a skill that's especially medical doctors or providers who take history use. You can summarize whatever the patient brought to you. Say, okay, so you are trying to tell me that you're having this, you're having that, and that, and that. Is that correct? Yes, just to have a broader view. So these are things that you shouldn't say. You don't actually tell the patient that I will tell you the truth. That man that you are with is not a good man. Move away from there. No, you don't force the patient to do anything involving set type of actions that go and do this, go and do that. No, not necessarily so. And even though it's part of some cultures, like where I'm coming from in Ghana, everything will be fine is quite a usual response, like asking somebody how he or she is feeling. It's almost like, should I say, an impulse. Like it just comes involuntarily. I'm fine, automatic. Meanwhile, you are not even fine. So you also being aware and sensitive of some of these things. Don't tell them everything will be fine. Don't change the subject. Yeah, boss, what brought you here? Charlie, just stress is something. Stress. We are all stressed. Must bring something better and stop that nonsense. No, don't dismiss it, and don't make the patient feel that whatever he or she is telling you is not real. On the NCLEX, there will be answers that will protrude in those things. I will show you how we answer questions around these areas. Okay. Don't normally say, wow, that's good. Hey, no, no, no. Yes, I mean, yes, in my country, there is a sound that people who interview others make, and it's quite difficult ascertaining whether they agree with you or not. It's like, say, oh, my name is Kofi Same. I was able to build a hospital for Ghana. They say, then it's like as if it's not true, as if it's true, you've done well. Like there's a reaction like that, right? Don't just say, whoa, good, and no. Unnecessary feedbacks. Don't do that. Patient says, I want to die. You can explore it further, but tell me about how you feel. Why do you think you have to die? Don't say, hey, don't say that. No. Christo ni ba te tu you quantify na Jimmy's no, don't do that. You don't tell the patient that. Sometimes a patient is crying silently. You can sit quietly for a while, mention their name softly. Say, Kofi, are you okay? Just so you know, I'm here with you, okay? Here with you. If you need any support at all, I'm just here with you. Sometimes you can stand, get close, a tender loving care if it is culturally appropriate and very necessary for you to do so. You can just give that type of tap and this kind of thing. But don't help them cry. I remember my mom in Ghana, when she comes to a funeral, sometimes she does not even know the person. She can just take some little details and that's all to it. The cry comes naturally. and she will flow. Oh, Charlie, who is dead? They say, Kofi Same. Who was Kofi Same? Oh, one religious guy. He used to play organ. Organ for which church? Methodist. Hey, Methodist. Then she will just, I mean, when the patients come to you and they are doing that, please. But when I worked in palliative care in Ghana, I realized I was crying a lot. I was a soldier, but when the patients come, especially we have something called breaking of bad news. So sometimes also, mom will hear this. Sometimes I go to the bathroom, cry a little bit, then wash my face with fresh water, and then come back to the patient. Sometimes when the patient is crying here in the US, you can even offer a tissue. Don't say take tissue, just offer it. The patient will see your hand coming in that gesture. They can take it, then maybe a tender loving care. Sometimes your actions, how you fold your arms in front of you, and all those things, they give a clue of your support thing that you're doing. So, as part of what we were discussing who a non-psychotic patient was. Okay, this patient is having psychiatric illness. Or but in context, enya adwinimuyare say others be. In the English language, the best way we can put it in our language for such people is not to say someone, but we will say bibi ehawomo, right? We will say there is something wrong or they are having a challenge, right? That makes it more respectful, acknowledging, does not sideline or stigmatize them in any form. Okay. So these were things that I was telling you, and as a quick summary, don't dismiss it, don't be judgmental towards them or give straight advice on your serious choices. No, present them as options that they should choose, and then they can choose. So the focus should be on, I'm reading for the last point, the focus should be on understanding the patient's perspective, validating their experiences, and exploring their feelings and thoughts. So I want you guys in the chat box, those everywhere you have a chatting space, write what you think of these kind of answers. There will be questions like this on the NCLEX that nobody might actually teach you. It's just universal knowledge and how sympathetic you are in our world, empathic you are in our world. Sorry, yes. So let's try some of these questions briefly, and then we move on. Okay. So I'm seeing a couple of answers. Because of time, you will just pick the first 5 answers. And just so you know, oh, good job, Coco. I see your answer. Good job. Clever. That's a very clever answer to pick. Let me pick the thing from the screen. So what I normally advise my student is that adults remember about 40% of something that they heard. If you want an adult to remember 60% of something, then you should involve visual, so audio visual. Then an adult can remember at least 60% of it, like we are doing. But if you want an adult to recall 90 to close to about 100%, that get them involved. You can't be a teacher and tell me you don't know this trick. If you don't know, I'm telling you, this type of teaching trick by involving the student, making them do something, is a way of helping them recall massively, about 90 to 100%. So if you are sitting on the fence and thinking that, oh, it's not necessary, it is very necessary. When you partake in the exercise, your brain creates a focus point for memorization for you, sometimes subconsciously, without you effortlessly doing it. It just creates it for you. We had a couple of answers in the chat, which says A. Others also said C, and I'm not making this up, but I think those who chose C are quite more than those who chose A. So why do you feel that way? Could be an answer, but over here, what the question is asking for is most appropriate. It means that others may be appropriate, but comparatively, others may be most appropriate in the superlative form. And I believe that the C is actually more appropriate comparative to the other one that we were talking about. Well done for participating. Let's try this quickly. Let's try this question. You are being reminded that after the class, there will be a recording of this section on YouTube. So you can go and watch, okay? So that you don't mix anything at all. Coco, I see you. Amadou, I see you. I don't know if Coco and Ama are tricking me. Their answers have always been C. Is it a trick or what? Ama, you think say what? Yeah. Doctor also said it's C. Okay, so yeah, Dr. Osodon, so Dr. Kofu said C. So, okay, the answer obviously is C. So we are now moving on from who the non-psychotic patient is to the psychotic patient, which will form majority of your NCLEX question. Okay, so you will get questions of this nature on the NCLEX. Just use your skills and the little bit that I've shared with you, understanding what the NCLEX wants from you in that regard. Okay, now let's go to the psychotic patient. The psychotic patient. For them, they lack insight. They are not reality based. They don't really necessarily know what is going on in their immediate environment or whatever is going on at all. And we have 3 types. Now, these types that we are doing is just going to be something mentally, so that when you are choosing answers and you don't know an answer to a question, you will use this as a guiding principle, but you are not supposed to necessarily memorize it. And I'm going to do more of talking at this point than making students come in. Okay. All right. Now, we have one we call functional psychosis. In my own language, I call it abodam. This is pure madness. Forgive me. There is no better way of saying it. So it's a primary mental disorder that is not caused by any medical cause. His brain is just off. Mm. It could even be that maybe he fell and hit his head against the ground, and then there has been structural changes in the brain, and that is it. The guy is off. Okay.
Hello, boss.
Yes, dear.
Sorry to interrupt, but I am unable to access my chat button. I don't know if the control is from your side.
Unfortunately,
I want to tap and type some of the answers, the initial ones you asked.
Okay.
I'm unable to access it.
Let's see. Can you try logging off and coming back in and see if it changes anything at all? Okay.
Okay.
Yes.
All right. Thank you.
You're welcome. I'm going to intentionally run in circles so as you can join quickly. Yeah. So for the functional psychosis, nobody's going to ask you the 3 types or anything. No. People even use other definitions for it. And we are not going to work on it, whether it's diagnosis, statistical manual or no. We don't need those things now. It's just a principle, just so that you know that maybe somebody went to smoke. The person felt so high and went even higher than the heavens above. And that's all. Decided never to come down. So you are talking with him and he's doing high, high, high because he's high. That is where he is now. You call him the high priest. And so things you see, we are all seeing humans. He is seeing Nimokafrem and Ayentemfrem. People mentioning their name to him. That is what he is saying. And there is nothing we can do about it. Proper madness. Functional psychosis. And then there is one that is dementia. When I talk of dementia, I'm not talking about the illness dementia, even though the illness dementia is a classical feature or example of this particular type, but I'm using it as something to represent all the neurodegenerative disorders. Talk of Alzheimer's, sometimes Parkinson's disease, what else? Dementia itself and all those kind of conditions. When you buy a new car, you don't expect the engine to be the same 20 years after riding it through time, right? There will be something going off. So your brain at a point in time, sometimes certain conditions, sometimes they are not able to clear certain chemicals in the brain, like beta, and then there could be tau tangles and all those things in the brain. Don't worry about them. Neuroscience is quite huge. Sometimes the brain cells are just dying off. The brain cells, unlike the hepatic cells or any of the other body type of cells, when they die, they do not regenerate themselves. They will not come back to life. And so you lose them for good. Okay. So dementia could happen. And I will teach you how to answer questions on the dementia type. Then we have the delirious type. And this delirious type, I'm taking it as you have a condition, let's say a medical condition. Maybe you have thyroid issues, thyroid toxicosis, and everything in your body is going up, and then it just overwhelms the brain control abilities, and you just become delirious, or in other words, confused. Let me use the basic terms. And so it's like you are portraying something like psychotic symptoms, but the underlying root is from an organ. So in some classifications, they call it the organic forms, right? So I'm just using my own simple explanations, just so the student will know. So we have the dementia groups, and then the delirium groups. So if a person becomes delirious in this context, it probably means that he was having an underlying medical condition, and it has escalated to that particular situation. Sometimes some substances, some medications too can send you to a delirious state. Okay, so let's look at something, a central theme that is so cardinal across all patients. We call them psychotic. The moment we tag you as psychotic, then it means this. It means you have something we call delusions. Delusions are false perceptions of nature or reality. You have an idea, but it's not real. Someone is following me. The government is spying on me. That my phone is being tapped. Sometimes it sounds, when we listen to your sentence, it's a real phrasing, a good sentence you phrase. But in your immediate environment and how we understand our world at that time, we see that what you are saying is not true. It cannot be verified. And these delusions, they have themes like paranoid, like persecutory. So paranoid delusions are the umbrella term or time and enmity. And it could be in the sense of people trying to harm you and then people actually harming you. So when we talk about paranoid delusions, it's the central theme is mostly around hatred, right? Hatred. and it's like people don't like me. They want to do this. Oh, they are stealing my this. They are taking away my that. They are tapping my this. They are on this. They may use it to. But if it involves physical harm, like they want to kill me, they want to unalive me, they want to do this, they want to do that, then if those are the teams, then we could liken it to persecutory because that one is going to deliver physical harm. Huh. Yeah, like you are going to be harassed physically, you are going to be touched and all those kind of things. Somebody is trying to poison me. My neighbors are trying to break into my home. Like this one involves some sort of physical coercion. So you could target in that regard. Okay. Yeah. And then we do have those that are grandiose in nature, like the person sees himself above all things. I quite remember when I was in Ghana doing my diploma nursing days, we went to Accra Psychiatry Hospital. And then there was an old reception somewhere there, and people don't even utilize it. We were there, and I don't know what had happened to this patient, how he got out from the ward, and how he got the cutlass in his hand. Two visitors, gentlemen in flying ties, who I think they were with, is it this bank, Unibank or something? No, Enterprise Insurance. Insurance people. I don't know what they were coming to insure at the psychiatry. I mean, if they were coming for the nurses or the patient, I didn't know. A patient just entered the room in the reception and said, "Behold, I am Jesus. I have come to bless you." Hi, hello. Come see the man for there. Then it took one lecturer there, and he was like, the teacher, he was not even bothered though. The way he was like solving the issue, he was like, "Hey, who is that there?" Then the guy turned and say, "It is me, thy master Jesus." With the King James bro for a King James Jesus. I said, "Jesus. So Jesus, what are you doing here on earth? Is it time for you to come and execute judgment or what?" I said, "I have come to bless these innocent ones." I said, "What?" The teacher said, Krachi, you see, look at these people sitting in front of you with those flying ties. Do you think these people need blessing? Just be honest with me. I doubt you are even proper Jesus. Jesus, you can't see these people already are rich. Why don't you send your blessings to the people in Ward 3 and Ward 4? Huh? The whole Jesus will come here. The room not even too hot for you. Then this guy, as we're trying to home 3, just circle like 3 times in the room. And do you know what is? They said, "As thou say it, thy master do it." Then he went out. I'm like, wow. So this is how smart we can use words and all those things to even bring people up. First of all, he was having something harmful in hand, but the team there, it wasn't like he was making the central team something of persecutory to unalive them per se, but you could see that he would have, but he had termed them as blessings. And so his blessings may not just be blessings the world will like to appreciate. And he's feeling big. He sees himself as Jesus Christ, which is quite a little bit grandiose in nature, right? And then we have somatic delusion. Soma has got to do with body, somatoform disorders, body, how body dysmorphic and all those kind of stuff. So for these particular types, they sometimes have issues with their body. And with this one, I'm gladly to tell our dear ladies and our gentlemen who think big is better, congratulations on your somatic delusions. You look at your thing and you think it's small. That is a delusion. I think I have every right to point it out to you. Yes, it may not necessarily be true. Our ladies who, I don't know. So let me end it here. But I think you are getting where I'm going and I'm dressing at. Yes. Don't have those type of delusions. There is a man that wants you for who you are. Sir, that size you think is small, it's not really small like that. There is a woman who will appreciate you for who you are, and you will have beautiful kids despite that size. Whatever this message means, please take it. It's COVID. Okay. Don't trouble yourself. And some of you who will go into counseling and deeper psychiatry, these are things that you will be working with. Lots of patients will be having some of these conditions, and you have to talk them through. There will be issues with intimacy and all those kind of stuff. So just be warned, just a little bit sensitive because today I'm on TikTok and I'm trying to keep the conversations a little bit sensitive and structured. Now, the other aspect of something, another theme that is common with these psychiatry patients is hallucinations. Now, I just want a simple feedback. There was a team that we just spoke about. What team was it? Somebody should just tell me the team we spoke about. Yes, we just spoke about something. What was it?
Delusions.
Delusion. Can anybody mention any type of delusion he or she knows? I mean, quickly, just.
Somatic delusion.
What else?
Grandiose.
Grandiose delusions.
Okay, grandiose.
Psychiatry delusion.
Sister Nia. What else? Last one. Sasa.
Paranoid.
Paranoid delusions.
Okay, all right. Well done. Now let's go to hallucinations. So for hallucinations, my main job that I will do is to dissociate it from what we call illusions. We have about 5 senses. Let me take the screen away from you and quiz you on it. What are some of our human senses in any way that you would describe it? What type of sense do we have? The sensory senses.
Tactile.
Smell.
Tactile. What is tactile? Tactile deals with what?
The sense of touch, the skin.
Touch. Okay, touching. Okay, what else?
Auditory.
Auditory. What is that one?
As a
Hearing.
hearing or ear.
Hearing.
Okay. Hey, you boys, Charlie, who are you more power? Just no mercy, you are blessed, my brother.
Amen.
Somebody said on TikTok, visual. Visual.
Vision.
Eye.
Yeah. Please, do we use only the eyes to see? Is the
No,
eye the only organ?
No, the nose. Smell.
Oh, okay. We can use the nose to see. Papa. Okay, so the smell, there's another name for the smell. What technical name do they normally use?
Olfactory. Olfactory.
Okay. Have we covered it all? Do you think we've left something out?
Sense of taste.
So all these things are there. Now, just a little bit of time wasting, something that is not needed for you to be in this class. But I'm going to talk about it anyway. You see, when you are doing your PhD, or even if you're doing masters in philosophy, sometimes they will bring you the philosophy of science and how we do research. Now, we have so many schools of this philosophy. One of these schools is what we call positivism. And at this positivism, we have empiricism. Now, for empiricist, I'm opening your mind a little bit, just an eye opener, so that you can use it wherever you go. An empiricist is somebody that subject or appeal to our body senses. He's saying that if whatever thing you are telling me is true, I should be able to see it. I should smell it. It should be touchable. I should taste it and I should hear it and that kind of stuff. So if whatever you are going to give me is not perceptible to the human senses, my brother, you are lying, take it away. So such person is likely going to be an atheist. I think you agree, right? You agree. That person is likely going to be an atheist because he wants a God to come in, like in the sky and say, "Hey, Charlie, I dare you, I beg." Make you not say I no day. Before he will believe. That is that kind of person. So empiricists are there. They are those who appeal to the school or body of research we call quantitative research. If all of us are here, 10 of us are here, and then we want to see how many of us are agreeing on this or are saying this or that, we just have to count. And when we count, we are all seeing the counting. So it is empirical in nature, right? So that is quite different from another school we call interpretivism or constructivism, where in these particular schools, we deal with interpretation. For example, when a person is in pain and you get closer to the person in pain, you tell the person, can you rate your pain on a scale of 1 to 10 for me? With 10 being the severest form of the pain, 0 means no pain, maybe mild, you give numbers and all that. Then the patient says, my pain is 9/10. Then it tells you that this pain is severe, right? It gives you an impression. So that is how the empiricist will work with the person in pain. But for me, who is probably a constructivist, what I will do is that, fine, you've rated the pain as that, but I'm going to ask you the quality of the pain. So we are going into qualitative research. It says, well, this pain is like it's aching, it's burning, it's throbbing, it's sharp, it's dull, it's that, it's this and that. Those are the qualitative aspect of it. It is also part of reality. So in research, you can do quantitative research and you can do qualitative. We even have a school called pragmatism, mostly from the US here. There's a guy called John something. He brought it. And then it's like, they say, we don't care. If the patient is in pain, whatever works is what we do. So whatever you are bringing, if it is useful, you use that method. So we don't care whether it is quantitative or qualitative. Those are the people that brings about a particular type of research we call mixed methods, right? That was just, by the way, that was just to delay you. That was just to also make you awake if you were sleeping in class. Let's move on to what we were saying. We started with psychiatry, how to approach it. And we said that, first of all, determine whether the patient is psychotic or non-psychotic. If the patient is non-psychotic, the patient has a grasp of reality. He knows what is going on. He doesn't look like he does not have an idea. He has an idea and can tell you, I'm not sleeping, I've lost appetite and all those things. But when we come to those who are psychotic in nature, they have no grasp of reality. They have what we call false perceptions about nature or reality, which we term as delusions. Then we've come to another central theme among these people we call hallucinations. And we realize that for them, their perception of what we think to be real and necessarily true, theirs is quite false in nature. It's contradictory to what reality gives majority of, excuse my language, sane people. So if we are all in a room, please don't go and tell the pastor so. If you are all in the room and you are the only person seeing an angel, it's questionable according to the psychiatric principles. Guys, are you with me?
Yes, sir.
Okay. So these are some of the reasons that we call them psychotic. Now, the other one is illusion. And this illusion, if you've ever lived in Ghana before, where Dumso thrive perfectly, you might have experienced some of this thing that I'm going to tell you. You were in the room. You have a wardrobe. You don't hang your clothes there. You decide to put it on a hanger behind your door. Then all of a sudden, ECG quench the light at the end of the tunnel. Ghana ECG for you, the light at the end of the tunnel. ECG. So they will off it. And then when they off it, there is a property of your eye. It begins to accommodate. Then before you see, that your clothes that you hang there, it turns into a monster coming to catch you. Then you try to see what your eyes are. Guys, haven't you experienced that before? The clothes in your room. And then it be sad at home.
Yes,
It will turn into something. So those are illusions. So what that means is that for illusion, there is a referent. When I talk about a referent, you refer to something, but you misinterpret what that thing is. It's like you are going to the psychiatry ward. You alone, a serious type of messy brace be, and now they connect you. You are going to do psychiatry. You've entered a psychiatry home, and then you are having this strange breath. A patient will see it, and he will tell you are the head of Medusa. He's seeing snakes and can even get frightened. Some of them will produce realistic emotions, will cry, scream, and shout for help. You, the next, may even feel terrible. But there is more sophisticated ones. I quite remember back those days, science class, when I was a science student, and I used to sleep a lot in class. One afternoon, a physics class was going on. I was sleeping. And then in my mind, I thought the teacher had called me to stand up. So I just woke up and started explaining something. And the teacher was like, what is going on there? And then I said, "Oh, sir, I'm sorry." I said, "Sit down and stop that nonsense." Then I decided to open my eyes wide and listen to something in class, at least for once in my life. And then he taught us something that I would never forget. He said that on a sunny day, when you move along, sometimes you can see something that looks like a pool of water ahead of you. This phenomenon, they say, is created by total internal reflection or something they call critical angle or so. And it is called a mirage. Guys, have any of you experienced a mirage before?
Yes.
Yes. So that thing that was there was a referent, but a misinterpretation of it. It becomes a mirage. We humans have a long way to go when we come to illusions. Magicians, somebody is in class and having wonderful conversations with the girlfriend. Ike, please kindly watch it for us. Okay. Okay. So for illusions, a lot of things could have that. Magicians use that to trick us. Mm. I think there was one I used to do. It was, guys, can you see this watch? Oh, I'm trying to look for something, and then I will use that thing. Okay. I have something in my hand. Guys, can you see this thing? Please, can you see it from your end?
Yes.
Okay. Yes, we can. So you see, now see, you see, I have opened my hand, but you see it hanging. Guys, can you see it hanging?
Yes, it's hanging.
But what you didn't see is that my finger is touching here. So if I am a magician, I can create that illusion for you. Hey, Papa Stem, I can create that illusion for you to think that it is real, but it's actually not real. So it's more of there is something you are referring to, but you are just misinterpreting it. Sometimes kids make that, and I normally use that in my arguments a lot. A kid that is learning by assimilation and accommodation. You would see a bird. They say, "Mommy, what is that?" He said, "Oh, it's called a bird." Oh, okay. The next day you are walking with the child sees an aircraft passing by. A very smart child's first comment will be, "Mommy, see a very big bird." Then yes, you now have to interpret the whole thing for the child, but that's just a misinterpretation. But this one is actually an illusion. Sometimes it's with the human perceptions. People can even feel that you touch him. Jesus Christ was walking, and then he said, "Somebody touch me. Somebody touch me." This is more like if there was no referent, would have been Jesus hallucinating. Somebody owned up, but you could hear from the disciples around him say, "Ah, what are you saying? There are a lot of people around here, so how can you even determine who actually touched you and all those kind of things?" These are interesting facts. So now we know who a psychotic patient is and who a non-psychotic patient is. How do we help them as health workers? Even before we answer questions on the NCLEX. Let's try this. I want to see the diversity. I want to prove a point. Please answer this from your best of abilities, okay? Don't listen to somebody's answer. He or she may be wrong. Antigati, Miriam, Rika, Papa Stem, Jill, the Wajina Swatchapa, Kono Bianso Jina Swap, and thank you. I mean, not TikTok for no answers, Nibi Kakra. How more answer? The Osha answers Nimo. BCB, BCC, BCA, BCC, BCA, BCC. I AC, 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 BCC, A bar, CCC, A bar. Now, I the A for Matiakoda, Mumma Bimrani and Query. and I'm demono. No, na be a baba, kuna a baba ko. Yeah, Jabon. What am I see? Okay. Interesting. So, guys, these are nurses, trained and qualified nurses, ready to go out and answer NCLEX questions. And you could see with the, should I use the word disparity? No, the diversity probably would accommodate that of the answers. We are all trained. We all learn psychiatry, but someone says A, others say B, one says C, one says D. And that means that we actually need people to guide us because there is a particular type of answer to these kind of questions that they want. In fact, the answer is A. And I'm going to mommy, it's a baby. What's the A?
Yay.
Hey.
So I'm going to teach you and guide you. That is why when we tell people that, you see, somebody went to write the NCLEX. He passed. And he came and all that he could tell others is, oh, Charlie, it's not too difficult. You can go away. In fact, if you had met this questioner, be honest, wouldn't you say it's not too difficult? You say that because this question, because it's just helping humans. But, and so when you did choose Ubidi and you pass, come and be honest and sincere and say, Charlie, I think you were just trying error and it worked. So that the one coming can prepare enough. Don't let it sound like the person does not need anybody to help him or her. That is a disservice. And what a friend of mine will say, you are poisoning the world. Yeah. So let's go to how to approach them. Those who have the functional psychosis, that abodam proper, schizophrenia, depression, major depression, mania. Hey, for mania, don't go there. Mania can make a person smart. Then we have to know the approach to help such individuals. Now, the trick is acknowledge their feeling. That's the very first principle. For them, present reality to them. And as it keeps going, set limits. And then you may have to enforce limit. So it's an example is a person with schizophrenia is experiencing, let's say, delusions, and he's saying the government is spying on them. He's making noise and they're spying on me and they're blah, blah, blah. When you get closer to the person, first of all, acknowledge the person. Say, oh, I can imagine how terrible it sounds or how disturbing is it for you to have the whole FBI spying on you 24/7. That feels like your privacy has even been taken away. That must be very scary. That must be distressing. That might be uncomfortable. You use those kind of words to acknowledge the person's feeling. Then you are going to present reality. I can assure, oh, thank you for the gift, Mamijo. I can assure you that there is no evidence to support the belief that the government is spying on you. I can assure you that there is no cockroaches climbing up and down on your hand. See, you have been making noise all morning. The patient is just walking around the ward and talking, they're spying on me, like just making. Say, I can talk to you, but I'm not going to engage you in a debate. No. Then you start setting the limit. You have to sit down now. We are not going to tolerate that. Sometimes you'll be firm a little bit, not to shout at them, but you build a point from an area. So while some books will just simply tell you to maybe set or enforce limit, that is too straightforward. We are nurses, and this is our approach. We approach with empathy, okay? We acknowledge. We are not saying that what the, excuse my language, the madman is saying is wrong. No. What that physically challenged person or mentally challenged person or intelligent issue guy is saying, we are not saying it's wrong or it's not existing in his world. But what we are saying that it is not congruent and say in agreement to what we are seeing in our world. It's not real. So we want to guide him bring him to our world, because our world is what is reality definition now, so that we can assist him on daily basis. So this is quite such, or one of the approaches that you have to use. Don't think psychiatry was just about going to the NCLEX and be seeing what drug is going to be. No, it's not almost always like that. And these things I teach, you see my students passing, you wonder why or how. These are some of the things that you may see. Now, let's put that one aside. Let's go to the psychotic patient as a result of old age or neurodegenerative illness, or let's say dementia. The brain cells are dying off or are not as sharp as they used to be, or whatever has happened. Okay. Now, an example could be Alzheimer, or maybe the person had a stroke. There was a cut of blood supply to a particular part of the brain, and they died off. And I told you that the brain cells, when they die, they die. When they die, they die. There was an argument once I was making with atheists. And you see, we have to pardon the old world. People arguing that Jesus might have not died. And I don't argue much about them, because the way we certify death these days is different from how they would have certified death those days. Coma would have been some form of death in those days certification. When we tell you, with the knowledge we have now, when we tell you you have the midbrain, the pons somewhere there is dead, and you are dead, you are dead. Somebody says you are dead. Proper death. Nothing is bringing you back. Unless we didn't diagnose you well, there was some sort of electrical activities that we couldn't really pick. But if they say you are dead and we bring our machines, we do electrocardiogram or something, and then we detect that there are no electrical activities, bro, forget it. You have to wait for the second coming of Christ to wake up, because for this time, dear, no. Empha. It is a high empha. Yeah. So these people have some of their brains worn out or something. For them, it's old age. Mostly, this is where the NCLEX bring the questions, and I wouldn't lie to you. It's a situation of safety. Guys, I said it's a situation of what?
Safety.
Safety.
I didn't hear the boy. I want a male voice.
Safety.
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 Yes, it's a situation of safety. So you acknowledge their feeling, but you redirect them. You will be there, then an old woman will knock on your door. Hi, Professor May, is he inside there? So, oh, Grandma, Grandma, this is not where Kofi Same is. Oh. So, Kofi Same is not here. Then you close your door. The next moment you will see, you will hear that old lady you sent away. You will see that he's on TV. And now they are announcing a missing person. The best you could do for her, and this type of redirection is not the type that you show fingers. So you go with the patient there. So you hold the patient's hands, and then you carry the patient to wherever you want to. So let's say, for example, no. Oh, Charlie Kwame, hey, your grandmother, I mean, she came to our side. Please, I beg you guys, pay attention to her a little bit. Then you help them. Have you seen that some of them will even tell you, oh, grandma, why? Kofi, ever since you went away, your wife have never given me food. For 3 weeks, I've not eaten in this house before. Guys, have you heard? It's what I'm saying first. I mean, is it real?
It's true.
It's true.
That's true.
It's true. Don't say, oh, don't do that. That is not the approach. Say, oh, Nana, I'm sorry. Ah, my wife was even telling me, say she was giving you, maybe it was too small. Me, I know, say it was too small. Don't mind her. What? We will try, and I will talk to her too. Now I'm going to make sure she gives you plenty things, and then I will change her mind to even love you more. How does that sound, Nana? I'm pretty sure Nana will be okay with it. Guys, what do you think?
Yes, well, I said, I'm pampa.
Yes. So these are realistic situations that are going to happen in our world, and they need genuine pragmatic efforts or real steps, real human steps to help such individuals. So please let's not neglect. So an example is a person with hyzemia is, let's say, experiencing some sort of hallucinations, and then they are seeing their diseased person around. The husband awovu some time ago. This old woman, let me pick somebody's name in the chat and then use it to make my example. Abigail is a common name in the chat. So Abigail, a 78-year-old woman in the room, is saying that she's seeing her husband, who was a driver. Na ne kunu no etwi impunam car from Odoko to Washiman. So this man had an accident and passed away. But the woman is seeing him, which is not real, making a whole lot of fuss, singing and other stuff there. Sometimes you need to be careful. There are some hallucinations, though I'll not answer them on practical exams, but realistically, I'll allow them to go on. Because some of them bring them great joy. Do you know that some of them bring them great joy?
Yes.
It even changes their mood. So if they are not going to harm anybody, if they are not destroying anybody, just a calm ambience of pure joy, please allow them. I'll just allow them to go through it. Just don't distort it. Though it is not reality. And in principle, if you are putting principles on, despite the father is giving him or her joy, we need to bring the patient back to reality. Because if it keeps going on, it gets to different stages. Okay. So for such a woman who was experiencing that, you say, oh, I can see the comfort it is. I can see how joyful it is to see your spouse. But let's have a conversation about your spouse. You see, the aim is that probably the spouse passed away. So when you bring a broad conversations about the patient talking to you about his or her spouse now, then the teams will be coming. We met here. We brought here. Then she now will bring the conversation to the point that say, until on 26th May, he had a terrible accident and died. You would have directed the patient in a very smart way, just to help the patient acknowledge what he or she is going through as a realistic world situation. Okay. Before I move on to the third one, guys, any questions at this stage? Please, is there any questions at all? But is what I'm saying self-explanatory? Is it okay?
Yes, it is.
It's okay.
It's okay. Great.
Yes, sir.
All right. Now let's go to the delirious type. That one, a medical condition brought it. It is also an issue of safety. It's an issue of safety. Now, let me ask you this question. What is the number one cause? The number one cause of confusion in the elderly?
Infection.
Infection. An example of such
UTI.
could be what?
UTI.
Is one of the commonest. When you see that they are confused, you need to check them. Now, a patient is confused. What are some of the precautions we should take?
4.
4. What goes into 4 precautions? Let me hear you. This is a major thing by the Joint Commission. So the NCLEX, for every question, every sitting that you sit, you should get a question about safety, mobility, and force, because the Joint Commission hails it a very serious issue. So we have 3 things. Force, CAUTI. What is CAUTI? CAUTI. What is CAUTI?
That's catheter-associated UTI.
Good. Fantastic. Catheter-associated urinary tract infection. So there will be a question around that area. Then there is another one. CLABSI. What is CLABSI? CLABSI.
That's central line.
Associated blood. My brother. And these are things, teams. A joint commission. You can see joint. They are all prioritizing in America. So why wouldn't they test you there? So when I go to work as a nurse leader, on daily basis, you have to review how many patients are on Foley catheters. And you have to do everything possible to take it out. Unless it's a chronic catheter. If the patient is post-op, first day post-op, we may allow, or maybe just to measure input and output. If the patient is in the ICU, we may allow. But on the casual ward, you measure it. Even if it is Pampers, you have to quantify it and on measured account, but give it a value, right? So it's not one of the entertaining stuff. And then we emphasize on principles in cleaning the IV lines and all those things before you give whatever medication that you are given. You swab. You swab for sometimes 30 seconds, and then you allow for it to dry for 5 seconds, and then you flush. Make sure the line is patent. Before you even go there, check, is there infiltration? Anything around there? Does it look like there's phlebitis, redness, leakages, blood around the site, dirty? I mean, all these things are leading to infection. So then the nurse leader is scavenging around, seeking for all these troubles to get rid of them, because those are the issues that is creating debt for the hospitals in America. If a patient is not having an issue and then they come to pick it in the hospital is slapped with it. Okay, back to our class. So the psychotic patient, we are talking about the one with functional psychosis, about that proper. That one you acknowledge, you redirect them, or maybe you try to present reality to them. You set limits and then you enforce those limits. Then you come to the dementia type, you acknowledge and then you redirect them. Then we are here on the delirious type. This one is from a medical condition. So my best bet, my advice is that whilst you acknowledge them and then you seek their safety, you also make sure that you treat whatever is causing it, the underlying cause that is leading to that. Now, back to the question I asked you about force. I wanted you guys to mention some of the things that would cause force. So let's come back to class. So what are some of the things that can cause force? Or if not cause crana, how can we prevent force? Let me ask it that way. How can we prevent force?
Good lightning.
Good lightning.
Avoid
Clearing of
slippery floors.
High floor.
Avoid what?
Slippery floors.
Okay, so what should you do rather if you are not going to avoid it?
keep it dry.
You dry it, you wipe it. Yeah, what else?
Non-slip
The
surface.
Somebody said no
Walk
rag
with
on the floor. Yes, what else? Non-slip
You
what?
can also put cautions or a wet sign, caution sign in case there is a water on the floor.
Practically true. Practically true. Yes, what else?
Remove racks.
Yes, no rust on the floor. Somebody on TikTok said that. Yes, what else?
You make sure patients with vision problems, they have their glasses
Their
around
aid,
them.
right?
Yeah.
Those hearing get their hearing aids. Those with vision get their
Devices.
assistive devices in terms of a cane, a walker, a wheelchair. They all should be close to the patient to minimize
side.
And in
Using
fact,
PPE, specifically non-slip shoes.
non-slip shoe will work for me. The PPE aspect, but I'll take the non-slip as 100% true. Side rails up. Somebody said it on TikTok. It's very crucial. And in the US, let me ask you, do you know that we have 4 side rails? Let's see if this is the bed. We have one here, one there, another one here, and another one here. When all 4 is raised up, what does it mean? Restraints. So we can't put all 4 up, right?
Yes.
Sometimes 2 up, 1 down, or 3 up, something, 1 down. Then we do that. Then you have to also nurse the patient on a low floor. He that is close to the ground wouldn't catch much. True or false?
True.
Now let me introduce you to the mechanics, something that makes the developed nation quite different. Have you heard of the bed alarms?
Yes, that was what I was about saying.
Yeah, about saying it. Let me allow you to say it so that you take your 3 points, please.
Bedside alarm, so that at least client could use that one to prompt in case of anything.
Yes, and we have chair alarms too. So even if the patient cannot prompt, for the patient to prompt, we call it call bell. Okay,
Right.
It's a call bell. That one you press on it, and then the nurses will come to you. But if the patient is confused, you set the bed alarm. Sometimes they exist in 3 modes. One of the modes will say when the patient gets out of the bed completely. The other says when the patient just sits upright. And one video is too sensitive. If the patient even move in bed, the alarm will go off. So that means it. Yes, dear.
Can we get pictures of like this call bell or something like?
I'll get them for you. You see,
Okay.
if it was just the Zoom, I would have just stopped the share and then click on something else. But I've made a setup so that I'm streaming on YouTube and on TikTok. And the truth is that this is my very first successful one. I don't want to jeopardize it. I'm scared. So I will send it to the page. If you are here, there's a probability that you are one of my pages. Those on TikTok who want to join my page, chat me privately. So I will post. So it's just a digital device, nothing, just like a phone, and then you are seeing. You can even Google bed sensors to prevent falls, and then they will give you them. So the beds come equipped with them. Some of them are just devices that you attach to the bed, and so it senses human pressure on it, and when the pressure is lifted, it goes off. It's just a very good mechanism. Okay. Now, the patient that is likely going to fall is 1, the patient that is old. 2, certain conditions will make you fall. 3, certain procedures we are doing for you will make you fall. When I mention certain conditions, I'm talking about dementia, any condition that is delirious in nature, anything that makes you confused, or potential for confusion, nursing care plan. Because if the patient is having a liver condition, there is a possibility of having the liver affecting the brain. We call it what? Hepatic what? Encephalopathy. Sometimes it could even be from a renal issue. So we could even have a nephro or nephritic encephalopathy or one of those things. They all happen, right? The body is quite connected. So these conditions will make you a candidate for fall. Then also having multiple infusions and things connected to you. Patient with a chest tube, he has this, he has that. It's also a recipe for fall. Good lighting, they've mentioned it. Then we need to give you what we call a fall risk band. A patient that has fallen before, according to research, is about a 55% chance. Just that I don't have the right details, so I'm not seeing it. So when we are assessing a patient that can easily fall, on the NCLEX, when they ask you which of these patients can fall, the one that has a history of fall is likely to fall better. Guys, what did I say? The one that has a history of what?
It's likely to
fall.
Yes. So they will ask the one that has fallen before can easily fall. And this, I'm not talking in terms of Joseph in Potiphar's household. This is proper fall. I didn't hear it too much. So we give a fall wristband. You put the bedside alarm on, third bedside alarm on. The side rails are up already. The bed is being nursed in there. And then frequent visit to the patient.
Yes, and I think you assist them to the washroom at least every 2 hours.
Every 2 hours. Yes, we call it rounding. You run on the patient, you ask them, are you having pain? Do you want to go to the bathroom? Sometimes the moment you offer it, he says yes. Put things closer to the patient. Don't keep them up there. Let them get closer to the patient. That is just by the way. Let's move on to class. We are still on psychiatry. And at this moment, if you are tired, I would entreat you to go and sleep. The host is not tired and he will continue to the end of the slides, but you can get access to the recordings on YouTube. Okay? You can get the access to the recording on YouTube. My name is Samuel Asamabwat, and you can type Psychiatry Review. You should find a couple of videos there. Most of my videos, I give it to the paid members, but 1 or 2 videos just for fun.
Mommy, not tired.
Oh, that's why you're tired, though.
Mommy. Not tired.
Listen, also you are tired. This is a chronic dear dance.
Say, oh, brain.
Even if it means moving out of the class, I mean, in future, small boy na kasasa. What do we need to computer to say? I want you to so be Okay, all right. Yeah, that's it. So the delirious patient, a patient that has gotten a condition and has gotten confused on all those things, is also one aspect of it. For them, you reassure and safety is paramount. So a patient with this condition, let's say you're saying I'm having cockroaches crawling under my skin. This is a pure tactile hallucination, okay? It's tactile. He's feeling it. They say, oh, I understand, like there are bugs crawling on your skin. Okay, that might be very uncomfortable for you. Oh, that must be disturbing, right? Do you know something? Let's go to the bathroom. I'll walk you to the bathroom. Because you are prioritizing safety, then you go and watch the patient. Because if you don't, the next time you come, the patient would have used razor. I don't know how many of you live in Accra. I don't know how many of you live in Accra. To go to Accra, getting to Novotel, I don't know the name of the hotel now. They have this Latter Day Saint church. One guy is physically challenged, no, mentally challenged. He has been shaving his hair. He has shaved that the whole place is red. I don't know if you've seen it before. Somebody might one day see him. Now I used to see him when I was in Ghana about 2 years ago. I don't know whether he has scraped his whole body off by now. Yeah, so you have to ensure that you walk the patient to the place and then you help the patients out. So these are some of the principles, and what you have to understand with the psychotic patient is that do not argue with them. Try to rather stay calm, be firm, be firm. Sir, can you say lower bed too? Yes, Preslamensa, I mentioned it. I mentioned that you less them in the low bed so that he that is down fears no fall. It's very vital, very important for you to nurse them in such lower areas. And thank you for sharing with us. I appreciate everybody that contributes to this particular section. Your comments and your ideas are not taken for granted at all. Okay. And this is psychiatry. Psychiatry is not even one of the things I liked. I like pharmacology, and you can go and watch cardiovascular pharmacology online. Those are topics I love. So when I'm teaching it, I feel good and I really put on my elements. But this too must be done. Avoid triggering their delusion. No, don't start it. In all cases, you should acknowledge their feeling, but you shouldn't start it. Don't say something that will initiate it. And then offer them help in a practical way. This is an issue we have with churches, with so-called politicians, with people in our universe. They are liars. A person has come to you, Pastor. Pastor, the person is saying he's hungry. It's not a matter of going on our prayers and praying. No. You have Gary there. Give him some. Let him eat first. Then we pray about it the next time. Guys, don't you agree with what I'm saying? Sometimes some of the patients now.
Yes, we do.
Do you know a hungry man is an angry man? A patient can become very, what's the word? Aggressive. Simply because he's not eating, right? Give him food and you see how healthy he will sleep. He will snore all day. So offer them practical help. Sometimes just the general mood, is not working. Get them some good shower. You will see how they resort back to factory settings at once. Now, if the person is agitated or aggressive, please, you are not a hero in this story. Always call for backup. Let people come and help you. And this is just by the way, in the US, guys, we don't tie people down like we do in Ghana. In Ghana, a patient threw a bro, I dodged, I took his hand and I sent him to the ground and I tied his hands. And everybody was appreciating me. There is a security man. You have to call them. You have to call condition security or something. It depends on which hospital you're working though. But the security will come and handle that situation for you so that you don't hurt yourself in the making. Yeah. Okay, so let's do a quick recap and then we move on to the next scene. We spoke about different types of psychotic patients, and in all cases, we said that we should acknowledge their feeling. If it is the functional types, you are presenting reality, and if the patient is proving stubborn, you set limits, and probably you may have to enforce limit. The enforcing limit can even end in seclusion. Guys, have you heard seclusion before?
Yes, boss.
Yes, please.
So it may end there, and it's allowed. It's part of the treatment, but it's the last resort. Dementia, look for answers that will acknowledge their feelings and direct them. Delirious type, look for answers that acknowledge their feelings and reassure them about safety. So when somebody is presenting any, excuse my language, psychotic symptom, let's say the patient is confused, try to ascertain what could cause that. Most of you will be working in the medical floor. So most of the time, it will be a medical surgical condition that has gone there. And that will be the delirious type. If the patient has a history of stroke, dementia, Parkinson's disease, multiple sclerosis, and all those things, myasthenia gravis, Guillain-Barré syndromes, those kind of hardcore neurological conditions.
Hello, boss.
Yes, dear.
Your voice is so low, as if you are too far away from the device.
Guys, is it like that at your end too?
As
No.
if now it's a bit better. Yeah, now it's better.
Cheers. Okay, I think I have to just open the volume a little bit for you guys. Is it still coming on clearly?
Sure, better.
Okay. All right. Hey, I didn't ask those on TikTok. Those on TikTok, is it clear still? Do you hear? Hey, do you hear? I'm in this. And I'm coming with can you hear us? Okay, thank you, sir. Yeah. So basically, these are the things we do, and you don't have to recall which of them is. Media show trim, media bonnet method. Media show trim already. Until how which one? When the patient is just sick, try to just acknowledge their feeling. Look at what the question is about and present something. Let's answer a couple of questions in the chat box, and then I will see how far the lesson has gone. Try your luck. Highly favored. I see you. Good job. Okay. A lot of people have answered, and I think most people are choosing B. I probably will agree and move on. Let's go to something that even when I teach you and I don't teach you anything in psychiatry again, I will say I've achieved in life. Depression. If you've ever traveled to any developed nation before, hey, unless you are not an African, you will appreciate something we call depression. And it is not a joke. In fact, it can lead to what we call a psychiatric emergency. So the NCLEX does not joke with it at all. Send me to any medical facility. Show me all the patients on your ward. For about 50% of your patients, I can suggest or predict that they will be on protonics. Or, why am I saying protonics? They will be on something for the stomach, right? A drug for the stomach. A proton pump inhibitor or something. It's likely. When you take that away, for a developed nation, probability that about 80% of your patients, if not have been on an antidepressant before, they are currently on it. It mostly helps. It mostly is the truth about the nature of environment the developing nation is. And it can significantly impair a person's daily life, relationship, and physical health. So, I'm not going to joke with it. I'm going to treat it as it is. Now, there is this diagnostic statistical manual. I mean, you don't have to worry about that. But of all these conditions down here, the patient should have at least 5 of them or more for at least 2 weeks for us to say that this person is diagnosed. If you tell me something, you told me, I come to you, we had fun and all those kind of things, and you say, oh, Charlie, you have a body odor. It can be sad. It's a natural human thing. Then within a day or two, I should be over it. I mean, this shouldn't be anything. But if I'm having that persistent worry continuously for 2 weeks, except that I can't sleep disturbance, I have lost interest in previously enjoyed activities, anhedonia. I feel guilt, feel worthless. I mean, same for just nothing matters. And some of you, when you come to the US and they start making you work in the hospitals, the truth is that you feel inadequate at all. But I promise that I'll do my best with these little teachings that I'm doing. I have you in mind. And so all the things that will make me look, excuse my language here, stupid, I've inculcated them into my slides, said that you wouldn't look same, so that you'll be empowered, you will know what is going on and work your way towards it. Okay? So there is energy loss or fatigue, concentration difficulty, and that is something that will really happen to you when you come. You can't even concentrate. You will learn things and then they are going away. In fact, for the concentration difficulty, people going to take exams and having anxiety could even have similar feelings. Okay. Appetite changes. You are even slow to reaction and all those things. Those are called psychomotor changes. Then the ultimate, which we don't want to happen, will be having suicidal thoughts. We actually don't want it to happen at all. Okay. So I'm going to move forward. And what I'm going to do is that, guys, please, can you give me at least, if you can tell me one sign or symptom of depression, I'll be grateful, please.
Weight loss or weight gain.
Withdrawal from loved activities.
Loss of appetite or eating too much.
Difficulty concentrating.
Lack of interest in activities.
What?
Difficulty concentrating.
Suicidal thoughts.
Insomnia. Less or more sleep.
Okay. They are all part. Now, they have different types of this. It could be a major depressive disorder, which has lasted for more than 2 weeks and is even more severe. And then we have one that we call the dysthymia. That one is a little bit milder. But it just, this guy, he's never had a very good move before. Always there, always low energy, low vibes. That's how he is for some time now. But it's not giddy giddy. Then we have postpartum depression that happens after childbirth. Now, the woman, why do you think a woman can get depressed after giving birth?
Lack of family support. Lack of family support.
Lack of family support.
Neglect.
Stress.
Stress from what?
Daily activities, like the daily routines that she's been doing alone.
12 o'clock, feeding the baby. You know, when biological wife delivered there, sometimes when the baby screams, it is, let me be honest, guys, don't beat me. It is sometimes the men that wake up first, so then we pretend we are deep asleep. Sometimes you use your leg to push sister small, push small, then sister will now wake up, then quickly pick the baby. But sometimes out of love, then we just help them. We sometimes take the baby sleep on our chest, then we send the baby back as if nothing happened at all. I think the last one is better for men to use. Let's help them out because they can easily get depressed from some of these things. Let's really help them. Do you know that a woman has given birth to 8 children and she's currently pregnant? All the 8 kids are girls. She went to do a scan with this one, and the guy at the laboratory is an apprentice. And he said, it looks like a boy. The woman said, don't say anything else. It's okay. So she went to buy boys' items. Guys, in fact, that guy, that apprentice needs some knocks. Do you know that the woman gave birth to twins and it was girls?
Sure.
And to say depression, no shy bear to say.
Yes.
That's right.
100 to the power 100.
Dr. Okofo, so you have experience. Sure, remember the tatis so you bought that is for them. Now there are some cases, they are very stubborn. When they are with their mama, they wouldn't do something. So maybe they are crying, they are with their man, then you say you want to lay helping hands. And then they will lie on you, the man's chest. Bro, forget it. When you take the baby out, the baby will scream like, let's say be a cry, you scream. If they see that you are becoming a bad boy or a bad man, they will don't use more. Yeah, sometimes that happens. So I appreciate you guys for mentioning some of the depressive symptoms, and especially for our pregnant women, a lot of things could happen. A woman was giving birth, and then right after giving birth, she heard a story. The husband had passed away. Guys, do you understand what it means? Yeah. Sometimes two life situations could come around and a whole lot of things could get them. And other times, it's no fault of theirs. It's just the pregnancy hormones messing with them. True or false?
True.
True. The hormones are trying to reset back to factory settings. Now, yeah. So your family history, chronic illnesses or pain, being in distress for a long time, substance use, postpartum periods, all could lead to that. Now let's come to my favorite topic, which will definitely probably end our discussion. That will be on suicide and its association with depression. Suicide is not a joke. And I'm glad to share this on TikTok as well. That suicide is a major concern in individuals with depression, especially severe depression. Suicidal thoughts or behaviors are both damaging and dangerous and are considered a psychiatry emergency. Thank you for liking a psychiatry emergency. So, if a patient is having suicidal ideation, it is not a one-time assessment that you do. You have to regularly assess for suicidal ideation and plans. The patient was saying something. He said, "At that time they had me, the way things they go, me if you don't go like me, I'll end it all." You heard him say that. Don't brush it off, guys. It's not a joke. Okay? And sometimes, if you don't take care, you the next two will follow. How? You will feel that you had every reason to prevent these things from happening, but then you didn't. So you may blame yourself.
Yeah.
Kwame. Now, there may be so I'm as a reason. You think you can me I doubt attempt. I don't think you can kill yourself. So how will you have killed yourself? Tell me, let me see. Guys, you see the trick? If you are lucky, that's I said kill myself. So the guy, he will explain every procedure. When you finish, please take all those harm and make sure you have methods to prevent them. Evaluate the severity, even the frequency, how he speaks about them, and how he wants to execute them. If the patient has tried previous ones, yes, note that it could be his only one principle or trick to use. And assess for access of little harm, such as maybe, you know, some patients can even harbor all their medications in their mouth and then take them one time.
Yeah.
Even sharp objects, they can use it to cause harm. Now, also, what we do is that you have to assess the patient for social support, because individuals, there are enough evidence to support that if you have a social support, you don't do certain things. Like, see the way I'm talking to you guys. I'm not saying I'm far beyond suicide, but considering the fact that I have you guys around, every now and then somebody is checking on you. Asabi, how are you? Please, about the CGFNS. Then I'll intentionally behave as if I didn't see that message. I did CGFNS for me, I'm now for one. They be a CGFNS. You know, so it keeps you active, it keeps you belonged. Yes, it belongs to an organized religion, an organized group. And you BBL, sometimes so-called atheists, you guys don't want to believe in anything. Some of these things, you, if not for the concept of God does not exist or God exists now, the social aspect of it, the belongingness that you get, the love that is built, the sense of community, that is what is missing, that makes it quite something unique. And when I or you should ask any patient about suicide, please go direct. Don't sugarcoat it. Are you planning to commit suicide? Ask it direct. It's a principle, a trick that works all the time. Ask it. Let them say they are no, but ask it. Sometimes they will tell you yes. Most times tell you yes. Don't be afraid to ask about specific plans for suicide. Ask it, because you may not forgive yourself if it happens. Treat all threats of suicide seriously, even including one that was said lightly. It's not a joke. He's lying. You can actually do it. And so when there is hopelessness and all the signs and symptoms we spoke about in terms of depression, depression sets the stage for you to commit suicide. Now, there is one cardinal sign that actually works most of the time for NCLEX. When somebody has been depressed for a long time, then you see a sudden change in mood. All of a sudden, he's happy. It means he's likely going to do what?
Commit suicide.
Commit suicide. Do you know what some of them do? They begin to share their things, right? Oh, take it, it's for free. Sometimes that is what they do. The NCLEX wants to know if you are aware of it. So please take note of that. We have skills in determine it. We have Columbia Suicide Severity Scale. Don't worry about it. I'll skip it for now. We can use it for actual attempts, those that the patient started but was not successful, and how he's even preparing it, right? So it's a very good suicide tool. A person is at risk if they show signs of plans to die. They may, one, give away favorite possessions or throw away important belongings, like I said earlier on. They become suddenly cheerful after a period of depression. Sometimes it's just some weird, bizarre thoughts. Each time you talk to them, say, hey, how it even came in crowd. Speaking of heaven all the time, they will tell you point blank, I want to kill myself. I'm going home. The earth is not my home. The other time I saw a WhatsApp post that made me laugh. You see the car speed, the speedometer. When we are going 100, I think the person was relating the speed we go with the him. And he said that if you are going 140 kilometers per hour, the him that looks likely is nearer my God today. And then when you go 160, that one, it says, this world is not my home. Just like, what the funny hymns, I'm like, oh, right. So these are the things that will make you know that, no, this guy is nearing suicide. Now, to manage them, we call it a psychiatry sitter. It's a one-on-one approach. So start one-on-one constant observation. Guys, you start one-on-one what?
Constant observation.
Is it the same as sitting at the nursing station and then seeing the patient?
No.
You have to be in the room with the patient, right?
Yes, sure. Yeah.
Now, we need to take certain things away. What do you think we shouldn't leave in the room? Let's go. Brainstorm.
Caps.
Next up objects.
What else?
Bell.
Bell.
Anything glass.
Anything glass.
Medication. What else?
Hand sanitizer.
Medications.
Okay, what else?
Sponge.
What else?
Sponge.
Phone charges.
Okay. What about clock?
No.
Clocks, yeah. Clocks.
Why would we take away the clock?
They can
rope,
break it.
the cable, the cable. They can use the cable to tie around their neck, or they can
The
use it
block,
to
no.
They
No,
can
the
even
Some
they
can
cable.
can
use
break it.
some can use to check time.
That is what the theory has it. That is what is documented by authorities. It's funny enough how people who commit suicide want to die at a particular time. I was born on 11th November at the 11th hour. So I would wish to die at 11th November at the 11th hour. Stupidity. Let's take the watch away and see how he assessed the 11th hour. What about mobile phones?
Yeah, it should be taken away because they can read online to check on how to do certain
Let's do it.
procedure.
Mobile phone away. If they want to make call, the nurse, the sitter there will have to help them do the call. And that they don't even have to make those calls. Somebody just came in and the person is giving us feedback.
However,
Yes.
these people, can you also take the bedstead itself away from their room and leave only the mattress?
Yes, in Ghana you can do that. In the US, no.
Oh, okay.
Yes. You don't even restrain them. You allow them. Just that you have a one-on-one constant sitter. And the sitter should not use his phone. The sitter sits at the entry of the room, observing the patient. Pens, papers are taken away. The patient is served in this paper plate. And we don't give cutlery set because nipa a cutlery. So we don't give those sets. Even the trash can is taken away. The bedside table is also taken away. Nothing should be left in the bathroom. Now, remove personal belongings and objects in the room that may present self-harm risk we've discussed. Security may be required to hold against you. At a point, though it's your life, but it's not your life. In America, you have a life, but it's not your life. And I'm glad to say that Ghana too, we have that law now. Are you aware that if you attempt suicide in Ghana and you are not successful, you can be arrested? Guys, are you aware?
Yes.
So it's the law now. Your body belongs to the war. No, not the war department. I mainly projected my military view on you. Sorry about that. In the military, every soldier's body belongs to the war department. So your body is not yours to be decorating it anyhow you want. Just keep the body ready for battle. And that's all the war department wants you. Keep in shape. Now, take the person seriously. Don't leave them alone. Involve friends, family, or other supportive or any support that you can get around. This is very important for us to pursue. Let me teach you the last thing. We answer a couple of questions and then we will draw the kettle down for the day. All right. The next thing I will give to you is what we call electroconvulsive therapy. Now, I have a whole slide on psychiatry medication, which is one of my strongest slides that I teach, but it is going to be for the paid group only. I wouldn't give it outside. If you are interested in the class, it is $50 for a month. It runs for just 4 months. You can hop in at any time. Just make sure you stay for a while. The least number of times somebody has joined our class or paid session and yet passed the NCLEX was just 1 week. The person came, requested that I just do test taking strategies alone with him, and that was a success. People also have done 2 weeks. What we recommend is the 4-month thing, so that you are adequately prepared and you might have gone to buy a 4-month cycle. You might have gone.
That smells like something.
It smells like something. I
Sorry,
think it
Asabi.
smells like kinky and fish.
Sorry, Asabi.
Okay. All right. So the class, I was talking about the class for 4 months. It runs, a month is 50. But let's say they've started already. This is the last one. You can join. You can join, do the conditions from this time. Then, because it's always running, it never ceases. It's constantly running. So anytime you hop in, just stay 4 months of that time and you get it. And my lectures are said that for every slide that I pick, it's an all in all. You don't need what we call maybe a requisite something before. No. I would make sure I teach it right. So that is my class for you. And we are nurses. I believe that not everybody will have the luxury of time or a synchronized time that we can all meet. So what I do, I record. And as you can see, this one is going free, so it will be on YouTube. I have so many means of recording. YouTube can keep a copy for me. I can make it private and give to my students only. Zoom, I've bought a whole cloud space, about 300 gig that I pay on monthly basis. I store the questions. So even people who completed classes with me as far as 2025 February, they still have access to the recordings and they still keep learning. And that's one of the good aspect of the class. You also have a community of students that will be with you. There's always people around that will guide you, and then you can form formidable mate. I have a question bank which is the cheapest in the market, and I will not say how equipped the question bank is, but go and try it 7 days for yourself. And especially those who have written the NCLEX before, that you had an idea about the nature of questions, you just go to my question bank and see how it sells itself to you. Okay, it's the cheapest in the market, $30 for a month subscription, and you have all the new questions. Now, one thing that you should know is that I have 2 WhatsApp pages. The very first page is 1,025. That's WhatsApp capacity. It's full. So sometimes sack people. And then I've created a page for past people just so that when I move them from the page, they can have a place to wait or be. Then we have a new group that is, I think we are around 300 or so that we are still accepting individuals. So if you're interested, you can join the second group as well. And imagine if I have over 1,000 people going to write the NCLEX and everybody will share their experience with me that, oh, when I went there, the weather was good. Some say that the weather it gives me an idea of what is going on. And this, we don't say publicly, but in all honesty, it is something, right? All right. So I will teach you the psychiatry medications soon. But this is psychiatry 1. I think I have psychiatry 2 and psychiatry 3 before we do the psychopharmacology. And with that one, you really grasp it because it works. It works on the NCLEX. Now, let's come back to class. Apart from me teaching the pharmacology later, we are going to do something we call electroconvulsive therapy. It's a brief, controlled electrical current that is passed through the brain to trigger a short therapeutic seizure, and it is used for severe depression. It kickstarts the whole thing. People think it's torture, but it is actually not torture. It helps. We can't promise that it wouldn't create discomfort. It may, but what mostly happens is that they will make the patient sleep. I'll teach you on the next slide. So it's first line when depression is life-threatening, or maybe the patient is having active suicidal intent. We have to, shock it back to factory default in temper. He's not drinking, doing all sort of things. Then we have to change the paradigm. It's also used when antidepressants are probably failed or can't be weighted. Because I'll teach you when I start the psychopharmacology that antidepressants or some of these psychiatric medications, they normally take 2 weeks to kick in. So don't expect to take them today and today night will work. No, it takes a while. And this works faster than the antidepressants. So it is a treatment, not a punishment, and it's done under general anesthesia with a muzzle relaxant. So the client may feel nothing. So before you, the nurse, which the NCLEX may ask, I don't know how they will ask it, but with the 2026 NCSBN update, I thought it wise to include this so that you know what is going on. So before the procedure, you have to make sure the informed consent is signed. Just treat it like a minor surgery the patient is going to do. MPU after midnight, you remove the jewelry, the indentures, have the client go and void, and you take vital signs to serve as baseline for the near future. You give pre-meds as ordered. The team gives the anesthesia and muzzle relaxants, everything for the patient to relax. Then afterwards, you put the patient on the side. So when the NCLEX asks you the best position after an ECT, you say place patient on his or her side. The rest will be the usual nursing care, vital signs, and the rest. Now, there will be short-term confusion and sometimes memory loss. It's quite expected. It does not stay for long. It corrects itself back with time. Headache, muscle soreness, and nausea are common and short-lived, and sometimes it can also come with not just a headache, but a bit of. I've heard somebody complain about blurry visions before. So that is that. Let's solve these questions in the chat box. Let's answer some questions and then we'll try and close.
For me, I'll choose. Can I choose?
Yeah. If you allow others to choose on the chat, like write your answer in the chat box.
That both, okay. Mm.
But what was your answer anyway? I want to hear you since you
B.
chose B. Okay, that's fine. All right. Let's try this question. Coco, I see your answer. Amadro, I see your answer. Thank you guys for joining. I think when you guys tap, maybe somebody who is preparing for NCLEX may have something small from this class. It's just, actually, this class is just something to educate the public per se, right? It's about depression and all those stuff. So that's why it's free. Coco fanza tapo so. This is the ama. On tapo mame. Watch it. I'm say at a 2.1K. Some ultimate pajama one the 5 cry. Yeah. All right. People have answered and they chose B. Obi fa A o but machada na mebu mani ego so. Wo bi so mu a, the wa fa A no. Oh ma. Let's try this. Dr. Kofo, thank you so much for the support.
Mm.
Ayi obi atwere wo TikTok say me patcho watwa. Enyi ni ma me nkɔhwɛ de me nkrɔfo na kyerɛkyerɛ no. Menyi ni bi ya no wati. Me hu ne say bi ya wati. Me nkrɔfo no say bi o. This time I check answers ni. Efua de wo de ade na to chacha. Efua si bi no asa twere A. B in a Bachelor of Arts and as a brown half. Okay, all right. Let's move forward. The answer was B. Let's go to this. If you have any challenge with any question, just draw me back, okay? Take your time and read. Don't rush. Okay. Most people are choosing 4. Okay. I think 4 is correct. Let's try this question. I'm a found sabo or phone suma enda moja. Why? Okay, lots of people have answered, but the answer is 1. Okay, let's try this question. Last week, see me try a deal with na class no local at once. Na hakabia take over. Na we see students no. Hey. Yeah, so but I say the meme it won't happen again. Once that motor poye no, I increase participants no. Okay, let me see what people chose. Hey, Puma also Jane 33. Did say one shut on Sunday season. All right. Let's try. The previous answer, please. Somebody's asking the previous answer. Amma, was it to this question? Amma, please confirm if it is this question and you are satisfied. If the answer is not clear, you can type and I would address it for you quickly. So are you okay? Please answer. Are you okay? Okay. Let's try this. Sama mensa actually forward see honum. Say panank waiting ka ye be me de pa. Na me see me no. Rather say me bomb in some bomb pa ya answers. Oh, sorry. Guys, what is the answer? Those online, what is the answer?
Choose 3.
It's 3.
Yes.
1.
It's not a joke. You have to initiate one to one. Guys, all too soon. This is where we draw, is it the curtain down or kettle or whatever? I want to pause here if anybody has any questions, seeking clarity and all that. Yeah, Amma Mensa is asking on TikTok that really, when we said 1-to-1, she said, really? Yes, so Nanama, we have a whole job to do. Now, my work as a nurse manager, when a patient is having suicidal ideation, it's a terrible experience. Why? Because if you have 3 aides assisting the nurses, one of them must go and sit. The 2 must now work the job of the 3. It is not a joke. It needs a 1-to-1 observation. Otherwise, you need to bring another person to come and sit with the patient and monitor the patient 24/7. Now, in the US, we call something a telesitter. Now, for a telesitter, it's an electronic device that we can set in the room. Somebody will be proctoring, like can monitor you remotely from elsewhere, the software company or trained individuals. And it has sometimes have out speakers. So they can even talk to the patient in the room. And mostly that one can be used for confused patients. It helps with staffing, but it can never replace what we have when it comes to a sitter in terms of a patient with suicide ideation. That one, you need a psych sitter. So that machine will be in the room and then the psych sitter too will still be there. Yes, that is the exception. She's saying, I thought you had to do the mental status examination before. In fact, what you are saying is true, and it is very real for nurses or healthcare workers. As part of our procedures, you have to examine anything or everything before you go, but not when the question has done the examination. Okay. So the client with newly diagnosed end-stage renal disease has been transferred to the behavioral health unit following a suicide attempt. How did they know that? It's some form of assessment, right? So this is a suicide issue, and there is no time to waste. The whole thing changes to be an emergency situation for safety. Okay. I would entreat you, if you're not in my paid sections, you can try. Or even if you can't afford my $50 monthly, you can always be in my WhatsApp group once a while. I do free class like this ones. Yeah, but we have more things and ways to pass. Now, I think the last time I did the statistics for the year, guys, anybody to help me recall how many of our members had passed? If any one of you recorded numbers that had passed earlier on, before, I think we more. April, are you trying?
Oh, actually, this is my first time joining.
Oh,
okay. First time, but I like it, so I'll come back.
okay. You are welcome.
Thank you.
So I think last year we had over 200 plus or so passes for the whole year. This year, we are in the middle half, and I don't think our numbers will look so good as compared to last year. I think we have 30 plus passes so far, and we're still adding on. By the end of June, I hope that we should get about 50 passes. So we are
Yeah,
in
I
June
think it's 39 passes, right?
39. Eh?
Yes, January 3, February 8, March 11, April 7, May 2, June 1. And then those that were private were 7.
So that was
making
39.
a total of 39.
And then 2 people have passed since that assessment. So that
Yeah,
makes
so
it 41.
41.
41. That brings it to 41. Okay. On we go. I'm going to, at this point, stop the recording. Thank you all for coming. Hope you had a great time. And then the rest will be a chit chat. But let me go to YouTube also and then end what I was having on YouTube. I don't think I was using this place. I think I use. Okay. That one is also in. I'll stop the share now. And I think
Thank you.
Yeah, at the peak of this class, we had is it 95 or so participants. Yeah, you can send me an inbox, join the WhatsApp group so that you don't miss classes. This is my first time of doing a live session across media spaces like TikTok. Yeah, for YouTube, I've done it before. Yeah, the other time we had a challenge. So we are quite good to go. Thank you all for coming. I appreciate you all. I wish you a very good weekend. Bye-bye.
Bye.